Hello, and welcome to the fifth event for the Meadows Mental Health Policy Institute's 2021 Speaker Series. I am Jessica Lim, Project Manager for the Child and Family Policy Team at the Meadows Institute. The Meadows Institute is an organization focused on helping Texas be a national leader in treating all people with mental health needs by providing nonpartisan, data-driven, and trusted policy and program guidance. And we're so grateful to have you join us today. As part of this 8-part speaker series, so far we've had experts share knowledge around implementation science, so ways to use data to meet your organization's needs, selecting evidence-based practices, and discussions around cultural humility and how it supports health equity. If you would like to watch or rewatch any of those previous webinars, those recordings can be viewed on our website. And our fall programming will be around sessions on financing evidence-based practices, measurement-based care, and collaboration. And we hope you can join us for those events as well. So up until this point, our series has been focused on implementation science. But for this session, we're going to take a brief departure to discuss something that's on many of our minds right now. So as children head back to the classroom, we're going to talk about ways to address childhood trauma and grief to promote child and family resilience. So for a bit of housekeeping, this 55-minute session is being recorded and will be available on our website in a few days. And since we're in webinar format, all attendees are muted and cannot share their screen. If you do have an audio or tech issue, please use the chat box and somebody from our team can help provide support. So for today's event, I'm so excited to welcome Dr. Julie Kaplow, who is a licensed clinical psychologist and is board certified in clinical child and adolescent psychology. She founded the Trauma and Grief Center in 2012 while on faculty at the University of Michigan Medical School and brought the center to Texas in 2014. As the executive director of the TAG Center at the Hackett Center for Mental Health, she develops, evaluates, and disseminates trauma and bereavement-informed best practices to community providers in Greater Houston, across Texas, and nationwide. Dr. Kaplow has published widely on topics of childhood trauma and grief, with over 75 peer-reviewed publications and book chapters. She's the lead author of Multidimensional Grief Therapy, co-author of Collaborative Treatment for Traumatized Children and Teens, the Trauma Systems Therapy Approach, and co-author of Trauma and Grief Component Therapy for Adolescents. Dr. Kaplow received her Bachelor of Arts in Psychology from the University of Michigan and her PhD in Clinical Psychology from Duke University. She completed her internship at Boston Children's Hospital, Harvard Medical School, followed by specialized postdoctoral training in childhood trauma at the Center for Medical and Refugee Trauma at Boston Medical Center. Dr. Kaplow will be taking questions near the end of the webinar, so feel free to submit questions or comments in the chat box, and we'll, as Dr. Kaplow is presenting, and we'll address those at the end of the webinar. So with that, thank you so much for being here today, Dr. Kaplow. You have such important information to share with us, and I'll have you take it away.
Thank you so much, Jessica. And I'm really honored to be here and talking to you about what I think could not be a more timely topic, which is, of course, trauma and grief, especially in the context of the pandemic and children returning to school. So today, what we're going to talk about is, first, I'm going to give you a brief overview of what we do at the Trauma and Grief Center at the Hackett Center for Mental Health. We're going to define a couple of terms, including trauma and bereavement and grief. We're going to talk about a theory of grief called multidimensional grief theory that really helps to explain the kinds of grief reactions that children of different ages might have. We're going to touch on the links between bereavement and suicide risk. We're going to distinguish between PTSD and grief and talk about why that is a difference that makes a difference. I'm going to touch on trauma and grief component therapy, which is an evidence-based treatment for both PTSD and maladaptive grief. And then finally, we're going to end with tips for both educators and caregivers and parents, all within 45 minutes. So the Trauma and Grief Center at the Hackett Center for Mental Health has really 4 main mission areas. And the first is to develop, implement, and disseminate evidence-based assessment and treatment for youth and young adults ages 7 to 21 who may have experienced any form of trauma and or losses. And we're going to talk more about the types of traumas that we're seeing in just a minute. We also conduct research on both adaptive and maladaptive responses to childhood trauma and loss, as well as treatment effectiveness. We provide training and professional education in both trauma and bereavement-informed topics and interventions. And we also translate trauma and bereavement-informed best practices into policy by attempting to ensure that all children across the state of Texas and hopefully nationally who've experienced trauma and bereavement receive the best practice care that they need and deserve. So what is a trauma? And I know I may be preaching to the choir here, but really just to make sure we're all on the same page, a trauma is the experience of a real or perceived threat to life or bodily integrity, or the life or bodily integrity of a loved one, and it causes an overwhelming sense of terror, horror, helplessness, or fear. And that word perceived is very important because what we know about trauma is that it is very subjective. So what is traumatic to one child and produces lots of intense reactions may not be traumatic to another child. And we know that there can be different types of traumas. So we have acute traumas that are sudden and usually one-time events like a car accident or a hurricane or bereavement or school shooting. But we also have chronic traumas that can go on for long periods of time. And unfortunately, these are occurring often simultaneously with acute traumas, particularly in our under-resourced communities. And these things include domestic violence, child abuse, poverty, and community violence. What we also know is that about half of US children will experience at least one trauma over the course of their lives. So this is not an insignificant problem. And in fact, it's a major problem. And we're going to be talking about what we're trying to do to attempt to resolve the issues that come from trauma and loss. So recognizing signs of traumatic stress in children can be very tricky. And the reason for that is because traumatic stress can resemble all kinds of psychological problems. This includes anxiety. So post-traumatic stress can present as anxiety about something bad happening to someone else in my family or something bad happening to me again. Attention deficit hyperactivity disorder, we hear this all the time, especially from teachers. So post-traumatic stress obviously has a hypervigilance component to it that can look like hyperactivity. So kids may be jumpy or on edge, and that can look a lot like hyperactivity. We also know that with PTSD comes avoidance, and that can look like distractibility. So a child not being able to concentrate because they're trying so hard not to think about or talk about the terrible thing that happened to them. And unfortunately, we see probably 95% of the kids that come in for services, for trauma and grief-related services, have already been diagnosed with ADHD. And once we chip away and figure out what's happened, oftentimes that is a misdiagnosis. With conduct problems, we hear this all the time from teachers. A child may be out of their seat, running around, completely dysregulated. And if that teacher isn't aware of the fact that a child has experienced a trauma, they may not be aware that they were triggered in the classroom by something that happened. So for example, if a child has been in a home where abuse has occurred and another child hits them or playfully, nudges them, that can set a child off who's been experienced PTSD, and they may be out of their seat and uncontrollable. So that's why we're very focused on helping educators understand what can trauma and PTSD look like in students and how can we address it. And then physical illness, we hear from pediatricians all the time that certain children come in regularly with headaches or stomach aches. And it's not until the pediatricians ask the right question about what may have happened to that child that they, continue to be confused about what might be going on physically. We know that post-traumatic stress can manifest as somatic complaints. So that's another area of training that we're very focused on. So I want to talk with you about an interesting experiment that can help shed light on why children have trouble learning in the context of trauma. And please don't get me wrong, I don't normally compare children to rats, but in this case, I feel like it's a very telling experiment. So this was conducted by Panksepp back in '98, and he studied rat play. And what he hypothesized is that when rats were in a calm, continuous environment, they would be able to learn from their environment. They'd be able to absorb from their environment, and they would actually experience what he referred to as joy. But when rats were in a stressful environment, and in fact, maybe even in a traumatizing environment, his hypothesis was that they would not be able to learn or absorb from their environment or experience joy. And so in this experiment, he had lab rats in a cage, and he studied their play. And so you can see over the first 4 days, the rats were playing nicely. And then all of a sudden on day 4, he inserted a single cat hair into the cage. Now, mind you, these rats have never been outside of the cage. But somehow they sensed the cat hair was there. And what happened was that they immediately stopped playing and froze in place. And what's really interesting about this experiment is that on day 5, the cat hair was removed, but the rats never returned to baseline. They never began to play again. And in fact, he followed them for several months, and that remained the case. Now, what does this mean for us? What does this mean for children? What this means is that we are wired to respond to danger and threats to safety. So imagine that a child is living with the cat or the perpetrator, and the perpetrator is removed or the child is removed from the home. We can't expect kids to just snap back and be able to learn, absorb from their environment, play like they normally do. What we need to be able to do is recreate a secure, safe environment so that they can then feel comfortable engaging in those activities again. So it's not to say that kids will remain frozen, but what it means is that we as educators and supporters and caregivers need to be able to support children after a trauma has occurred in order to get them back into that calm, continuous state. So this is a really key question, right? The $1 million question. So what we want to do is move away from the question of what's wrong with that child and ask the question, what happened to that child? So I'm not sure if others have read the book by Bruce Perry and Oprah Winfrey with this exact title, but the message here is that when it comes to trauma and grief, we need to be asking about what happened in the child's environment that is creating those behaviors in the classroom, at home, and not asking what is going on for them, what is wrong with them. So the long-term consequences of unaddressed trauma are very significant. So we know that if we don't address trauma early on, children tend to have smaller brain volumes, especially with chronic trauma, depression, suicide risk, school problems, problems with their peers, substance abuse, violent behavior, delinquent behavior, and even the intergenerational transmission of trauma or traumatic stress. And I would go so far as to say that the majority of society's most significant problems actually stem from unresolved childhood trauma. So if you think about things like community violence, domestic violence, sex trafficking, the majority of the individuals perpetrating these things have experienced early childhood trauma. Now, again, that's not to excuse those behaviors, but what it means is that imagine a world in which we could intervene early so that those things would never happen. We might have a very different society if we're able to do that. So I want to turn to a very important form of trauma called bereavement. And I know most of you understand what this is, but just to make sure we're on the same page, bereavement is the experience of deprivation or loss by death, whereas grief is the psychological or behavioral response arising from bereavement. So in other words, bereavement is to trauma as grief is to PTSD. So we need to really understand that there is a difference there. And what's interesting is that the literature has focused primarily on links between bereavement and problem outcomes, but very little on links between grief and future psychological outcomes. And that's an area that we are very focused on here at the TAG Center. So why are we focusing on bereavement in particular as a particular form of trauma? First of all, it's the most frequently reported type of trauma in clinic-referred youth across the country. It's also the most common form of trauma worldwide. It is the most distressing form of trauma among adults and youth in the general population. So if you were to ask anybody, what is the hardest thing that's ever happened to you? The vast majority would say it was the death of so-and-so. It's the strongest predictor of poor school outcomes above and beyond any other form of trauma. So this was a study conducted by my former postdoc, Ben Osterhoff, who looked at about 14,000 students across the country. And what he found is that the sudden death of a loved one was an even stronger predictor of poor school outcomes, including school dropout, poor school grades, lack of school connectedness, above and beyond other forms of trauma, including sexual abuse, physical abuse, domestic violence, witnessing domestic violence, being in an accident. So what does this mean? This means that oftentimes schools are unaware of when children are experiencing losses, and we need to help make them aware, given what we know about those sudden deaths and what can happen to kids in the classroom after something like that. This is also particularly relevant for youth of color. And the reason for that is because they are obviously experiencing higher rates of COVID-related deaths. We know that our Black and Brown communities are experiencing much higher rates, and also exposure to violent death. So those sudden deaths really come into play when we're talking about under-resourced communities and also communities of color. And this leads me to talking about bereavement among justice-involved youth. And this is a topic that really hasn't been explored very much, although it should, from my personal opinion. But what we know is that most detained youth report the death of a close loved one, with over 70% experiencing at least 2 or more significant losses. We also know that detained youth report experiencing their first death on average by age 5. Deaths are most frequently characterized by violent losses in this group. And more than half of detained youth report the death of a primary caregiver, although a minority of these primary caregivers are actually parents. So oftentimes they are aunts or uncles or grandparents. And so what that means now in the context of COVID is that many of these youth are losing their caregivers due to the fact that those are the individuals who are most heavily impacted by COVID-19. So we need to be really aware of the fact that this population is at very high risk for experiencing losses. And there are lots of links that we can talk about between early childhood trauma, loss, and then future delinquent behavior. And we know that there is that school to prison pipeline that we're going to be talking about in just a minute. So children's grief reactions, and not simply bereavement, play an important role in future psychological functioning. And that's why we're very honed in on the grief piece in particular. So I want to move to the grief theory that I had mentioned earlier. And I've had the honor of working on this very closely and carefully with 2 colleagues from UCLA, Bob Pynus and Chris Lane. And what we've found both through our research and our clinical work is that grief in childhood is multidimensional, and it's actually 3-dimensional. And what I mean by that is that it appears that children experience grief, 3 different bereavement-related challenges that are very prominent in childhood. The first is separation distress. This is yearning and longing for the person who died. The second is existential or identity distress. This is feeling lost without the person, or how am I going to get through life without the person? And the third is circumstance-related distress. This is exactly what it sounds like, being very preoccupied with the way the person died. So I wish I could have intervened, or I wish they hadn't had to suffer so much. But what we also know about each of these dimensions is that there's an adaptive counterpart. So with separation distress, for example, I was treating a young girl whose mom died of cancer, and she was very close to her mother, and so was obviously devastated. And when we were working together, we started to have her engage in behaviors that she used to do with her mom. So things like making her mom's favorite apple pie, or taking swim lessons, because that was something she and her mom loved to do together. And the more that she engaged in those behaviors, the more that she felt close to her mom, but in a very different way. So reinventing that relationship so that she could still feel close to her. That would be the way that we would think about adaptive separation distress, or dealing adaptively with that particular issue. Existential or identity distress, we hear from kids all the time, things like, I don't know how I'm going to get through life without my dad, or I don't know what I'm going to do without him. And what we also hear simultaneously are things like, I want to do things that would have made my dad proud of me, or I want to live the kind of life that my dad would have wanted me to live. So that would be an example, again, of dealing adaptively with existential identity distress. And circumstance-related distress, we see this all the time, where kids will naturally gravitate toward trying to change the circumstances of the death into something meaningful that can help other people. So for example, I was working with a 10-year-old little boy whose father died in a tragic plane crash. And I asked him, what do you want to be when you grow up? And he said, when I grow up, I want to be an engineer so that I can make planes that don't break anymore. And so again, we see this tendency to want to repair whatever happened to their own caregiver or their own sibling or loved one in order to prevent others from having to suffer in the same way. So kids may raise money for breast cancer if mom died of breast cancer. And in fact, many of society's greatest inventions stem from tragedies that harmed other people. So even things like seat belts, Mothers Against Drunk Driving, even fire exits stem from having experienced a tragic death. So what we want to do in our treatment is to be able to harness those more adaptive responses to grief in order to help children to heal over time. So I want to give you a few examples of what this looks like. And these are illustrations taken directly from trauma and grief component therapy, which is, I'm going to tell you more about that in just a minute. But this is an example of separation distress. So this is a boy whose father died, and his mom is handing him tickets and saying, your dad would want you to enjoy these tickets. Why don't we go to the game together? And he's thinking to himself, I can't ever go back there anymore. I won't ever be the same without him. So we see this very frequently where kids will avoid doing things that they used to really enjoy doing because doing those things without the person there is just too painful for them. This is an example of existential or identity distress. This is a girl who just got accepted to the college of her choice. And unfortunately, her father had died and he was her biggest cheerleader. And she's thinking to herself, I don't care about my future anymore if he's not going to be a part of it. He'll never see me graduate anyway, so what's the point? So we often see this in adolescence where kids will give up on their future hopes and dreams and aspirations if the person who was most supportive of them and really pushing them through that is no longer there. And then this is an example of circumstance-related distress. This is a girl whose brother died in a gang fight. She's thinking, every time I see his picture, I can't help thinking about the night he got killed. It gets me so mad that it's hard to remember the good times. So she may want to positively reminisce about her brother, but anytime she thinks about him, she is flooded with those very upsetting and scary thoughts and feelings about how he died, and she's not able to have that more comforting image or comforting memories of him. And this is another final example of circumstance-related distress. And we see this very often with stigmatized deaths, like drug overdose. This is a girl whose father died by suicide. She's thinking they'll never want to hang out with me once they know the truth about how my dad died. So we see this where kids will sort of isolate themselves or demonstrate a lot of social withdrawal because they feel uncomfortable or embarrassed or ashamed of the way the person died. And the problem with that is that one of the things that we know can precipitate suicidal ideation is feeling isolated and different from others. And we're going to talk more about that in just a minute. So why is this multidimensional or even three-dimensional framework important? It's important because we know that different dimensions of grief may be more prominent at certain developmental stages. So for example, what we're starting to see through our research is that separation distress tends to be more common in younger children, whereas the existential and identity distress seems to appear later in adolescence. Different dimensions of grief may not be present in all bereaved populations. So when we first started doing this work, we were working with children in Ann Arbor, Michigan and Detroit, Michigan. And what we found is that they had equal levels of separation distress, but the group in Detroit had much higher levels of circumstance-related distress. And the reason for that is because the youth in Detroit were actually witnessing homicides all the time, whereas the kids in Ann Arbor were not. And so what that means is that we would want to tailor our treatments to ensure that we're addressing the different dimensions that those kids are most elevated in, which brings me to my third really important point, which is different dimensions may require different treatment components. So in other words, we know that a one-size-fits-all grief treatment is not very effective. And the reason for that is because we know that kids grieve in different ways, and they may be dealing with those different grief-related challenges at different levels. So we want to make sure that we're meeting them where they're at. And that's exactly what the treatments that we're using really attempt to do. So I want to talk for a minute about suicide. And we know that this is a major public health concern, especially in the context of the pandemic. We know that even before the pandemic, it was the second leading cause of death among adolescents. 18% of high school students report seriously considering suicide, and 9% report an actual suicide attempt in the last year. And again, these were figures that were derived before the pandemic, and we know that those have increased since. We also know that adverse life events are linked to suicide risk, and these include all of the below. So physical abuse, sexual abuse, family violence, discrimination, natural disasters, but especially bereavement. And so, sorry, I know this is a repeat, but I want to hone in on this link between suicide and bereavement. So with suicide ideation, we also have sometimes what's referred to as reunification fantasies in bereaved youth. So this is an example, again, taken from trauma and grief component therapy. And this is a girl whose best friend died and she's driving recklessly. And she's thinking to herself, it doesn't matter if I live or die. If I crash, the bad news is I'm dead, but the good news is I get to see my friend again. Now, this may sound very extreme, but what we find is that this is a very common grief reaction where kids will actually think about how they might be reunified with the person, and that can lead to suicidal ideation. So this is something that we, on the one hand, want to normalize, but on the other hand, we want to pay close attention to given the risks involved. I also want to touch on this interpersonal psychological theory of suicide because I think it sheds a lot of light on why bereaved kids are more at risk for suicide. So in this theory, Joyner talks about two major factors that have to be present in order for someone to actually go about dying by suicide. The first is thwarted belongingness. This is really just sort of a fancy way of saying a sense of loneliness or perceived lack of support. And perceived burdensomeness. This is when one has felt or feels as though they're a drain on the resources of others. So I'm such a pain, no one needs me in their life, I'm better off dead. And so what we see, and these are quotes taken directly from some of the kids that we've worked with, is that thwarted belongingness is very prominent in the minds of bereaved youth. So things like, nobody understands me, no one knows what this is like to have lost a parent, for example. People think I'm weird because I don't have a mom anymore. Or anyone I get close to dies, I shouldn't get close to anyone anymore. We also see perceived burdensomeness in bereaved youth. Mom starts to cry every time I mention how much I miss dad. Or if I had been better behaved in school, mom wouldn't have been so stressed and had a heart attack and died. So that perceived burdensomeness can come from stories that kids will invent in their heads about the way that they may have been responsible for the death. And we're unfortunately seeing that more and more with COVID-related deaths, as we know that children are able to transmit that to others. So I want to just, again, touch on bereavement-related risk factors in the context of the pandemic, thinking about all of what we just talked about. We know that we are seeing increases in thwarted belongingness as a result of social distancing. So social distancing shouldn't have to mean that people are socially withdrawn, but oftentimes that is what has happened. And so often in the event of a death, especially during the time of the funeral or in the weeks following, kids are not able to receive the needed social support that they would normally receive because of those social distancing restrictions. And so many of our kids during the pandemic who lost someone were not able to have that necessary social support. Increases in perceived burdensomeness as a result of ongoing pandemic-related stressors. And what we mean by that is that kids are seeing their parents stressed. They are seeing that, especially in the context of having lost a loved one and during the pandemic, that surviving caregiver may be extremely stressed, may have lost their job. And with the pandemic going on around them, those stressors are amplified. So that can make kids feel like, maybe I'm better off not being here. I'm just an added burden to mom or dad or whoever the person is. Youth may be at higher risk for suicide as a result of the circumstances of the death. And we're going to turn to that right now, actually. And so this begs the question, well, in terms of circumstances of the death, how do we define traumatic bereavement? What is considered a traumatic death? So what I'd like to do now is share with you a couple of anecdotes. These are actually real youth that we've worked with. And these are case studies that we've sort of talked through and thought about. But I want to share with you two of them today. And one is a 9-year-old girl who was in a tragic car crash with her mother and father. Mother is killed after suffering from numerous internal injuries. The child is not hurt, but observes her mother's lifeless body from the backseat of the car. So I want you to have that in mind as we go through this exercise. The second is a 12-year-old boy who experiences the anticipated death of his mother after suffering from breast cancer for 3 years. The child served in a caretaking role during that time and had ample opportunity to say goodbye. So as you have these kids in mind, I want you to sort of picture what they might look like, either as a student or someone coming into your office, but imagine how they might be presenting to you. And now I'm going to share with you a couple of quotes. So the first is, this child presents with extremely high levels of PTSD, minimal symptoms of maladaptive grief. During the interview states, I just keep remembering it and I feel like I'm right back there again. I can't get it out of my mind. So I'm going to ask you a poll. I'm actually going to poll you and ask you the question of which child said that. So in your own mind, as you're thinking about these kids, was this the 9-year-old girl who lost her mom or the 12-year-old boy who lost his mom? And you can fill that out and we'll give you a second to share those results. Okay, so let's see what people said. So slightly more thought that this was the 9-year-old girl and less thought it was the 12-year-old boy. So only 22% thought it was a 12-year-old boy. Okay, very good. Now we're going to go on to the next quote. The child presents with high levels of separation distress and existential distress, minimal symptoms of PTSD. During the interview states, my mom was like my best friend. I just want her back. I just want to see her again. So again, we're going to do the poll. And again, was this the 9-year-old girl who lost her mom in a car crash or the 12-year-old boy who lost his mom to cancer? And we'll give you just a minute to answer that question. Okay, now let's see what people said. Okay, so more of you thought that this was the 12-year-old boy and less thought it was the 9-year-old girl. Okay, so I'm going to show you the answer here, and it may not be what you thought it was. So this was what the 9-year-old said. So this is a 9-year-old girl, presents with extremely high levels of separation distress and existential distress, minimal symptoms of PTSD. During the interview states, my mom was like my best friend. I just want her back. I just want to see her again. So I have to tell you that, the reason I posed these questions to you is because I, like many of you, had imagined that this child would have very high levels of PTSD. So before she came to our clinic, we had anticipated that. She was in the car at the time, she witnessed the entire thing. And so again, imagine that she would have those high levels of PTSD. What happened was when she came to the office, and the way that our trauma and grief clinic was set up at the time is that I was behind a one-way mirror. We had a number of team members with us. And then one of our postdoctoral fellows would do the intake interview with this child and provide the treatment. And I have to say, it was probably the first and only time I can remember that no one behind the mirror had a dry eye. We were all crying. And the reason for that is because this child's sorrow was palpable. Her separation distress was palpable. She just wanted her mom back, but there was no sign of PTSD. And in fact, when we did the standardized assessment with her, where we looked at symptoms of PTSD, symptoms of maladaptive grief, sure enough, she had almost no symptoms of PTSD. And in the back of my mind, I thought, well, maybe that'll change over time. And it never did. And really what this child needed was ways to feel connected to her mom. And that's exactly what the therapist did with her, with the help of her surviving caregiver, dad. And I really believe that if we had gone down the road of treating trauma and PTSD and having her do what we call a trauma narrative, where we talk about the circumstances and what she saw and thought and felt during the car accident, I actually think it would have caused damage. Again, that speaks to the importance of really looking carefully at how these kids are presenting by using a more standardized assessment and also not jumping to any conclusions about what they might be presenting with. Similarly, this was another surprising case. This is a 12-year-old boy who presents with extremely high levels of PTSD, minimal symptoms of maladaptive grief. During the interview, he states, I just keep remembering it, hearing my parents crying together in their bedroom and my mom saying, I know the treatment isn't working. I feel like I'm right back there again. I can't get it out of my mind. And so this is something that is often overlooked. When kids are experiencing an anticipated death, they might be seeing and hearing about very traumatogenic images and experiences that the adults may not be aware of. In fact, we know that the sound of adults crying can be extremely traumatizing to kids. And even seeing, the slow progressive deterioration of a caregiver can be extremely traumatizing. So what we want to do is help to educate, clinicians about the fact that even though that's an anticipated death, there's sort of this sort of old wives' tale that if you can have closure, if you can say goodbye, that you will not develop PTSD. We know that that may not be the case, and that many kids who are experiencing anticipated losses, particularly in the context of COVID, are experiencing PTSD and trauma. And in fact, when we looked at this with our own data, we were able to replicate this with a much larger sample, but this was one of our initial studies where we looked at kids who had experienced an anticipated death of a parent versus those who experienced the death of a parent by accident, so a car accident, or a sudden natural death or suicide. What we found, obviously, is that those who experienced the anticipated death by illness had much higher levels of PTSD than both accidents or sudden natural deaths. So again, this speaks to the need to be paying close attention to kids who are facing an impending loss, given that they do appear to be more at risk for PTSD. Now, that's not to say that they are higher than suicide or homicide. We know that both of those kinds of circumstances do precipitate higher levels of PTSD. But again, this story here may not be intuitive to folks. And so it's something to be paying close attention to. So why is this difference between PTSD and grief so important? Well, we know that there is a difference between what we refer to as trauma and loss reminders. So trauma reminders are images, sounds, smells, people, or situations that remind the child of the traumatic event. And this is what often leads to symptoms of PTSD. Whereas loss reminders are images, sounds, smells, people, or situations that remind the child of the absence of the person who died. And this is what often leads to grief reactions. And the way we go about supporting kids who experience trauma reminders is different than how we support kids who experience loss reminders. And I want to give you an example of this. So this was taken from transcripts that we had within a semi-structured interview that we were testing out with children. And this was a 17-year-old girl who had not only witnessed the murder of her mother by her father, but she had actually tried to intervene. So she was highly traumatized. And so the clinician says to her, do you get very afraid, upset, or sad when something reminds you of what happened? The patient says, oh yeah, screaming, the door slamming, firecrackers, that, and seeing or hearing arguments. Whenever I hear somebody fussing or anyone arguing, especially if it's a man, I want to run and just go get a knife. It brings me right back. I get to the point where I'm so scared, I'll kill you if you make another move. I wouldn't mean to do it. It's just out of fear. They could even just be playing, but just hearing that scream, it just makes me feel like I'm back there again. The clinician says, and when these things happen, how much do they bother you? She says, on a scale of 1 to 10, I'd have to say 20. So if you can imagine, we have so many kids in our communities who've experienced traumas and losses who are going through this daily in school settings. So screaming on the playground or doors slamming in the school. Firecrackers, as you know, was for her resembled the sound of the gunshot, but even seeing or hearing arguments. So if you can imagine, these kids are experiencing these things not only frequently, but that intensity, and you can see here that she said, I'd have to say it was a 20, is very extreme. And so again, this is where we want to be able to educate educators and teachers about how these things can be triggering to kids in the classroom. And then the clinician goes on to say, and have you tried to stay away from people, places, or things that remind you of what happened? She says, I can't go to the mall anymore. I went only one time after she died, but I couldn't go after that. There's a lot of stores. Oh, sorry, I shut off my video by accident. There's a lot of stores and stuff that I like there, and I want to go so bad, but I can't because I don't have my mom anymore. The clinician says, is that because the mall reminds you of what happened? And she says, the mall just reminds me of her in general. Through good times and bad times, we always went there together. So this really distinguishes, this is not a trauma reminder, right? This is a loss reminder because again, it is too painful for her to go to the mall because she just misses her mom. And so these are also things that come up all the time in situations in school, where kids, for example, are, having to write Mother's Day cards in the classroom and a child had just lost her mom. We want to help teachers to become aware of these things, of these really potent loss reminders, so that we can help them to prepare their students for things like that. And so this also speaks to the need for treatments that distinguish between trauma and grief. And I'm just going to touch on one right now. This is trauma and grief component therapy. This is an evidence-based intervention that we've been using in many different settings under many different circumstances. So it was first used in Bosnia, believe it or not, after the war. It's been used post 9/11. It's been used after Columbine. We've been using it, we had used it after Hurricane Harvey in schools and other settings, and also after the Santa Fe school shooting. And the beauty of trauma and grief component therapy is that it's very flexible and can be tailored to the needs of students. So for example, the first module is really just about basic coping skills, emotion regulation skills. The second is where we move into trauma processing. The third is grief processing, where we want to reduce the maladaptive grief and harness those more adaptive grief reactions. And the fourth is getting them back onto a normal, healthy developmental trajectory. And again, with the schools that we've worked with and the school counselors, what we've tried to do is really help them to tailor this to meet their own needs. So for example, if you're dealing with students who are primarily traumatized but not grieving, you could do modules 1 and 2. Or if you're working primarily with bereaved children, you could do modules 1, 3, and 4. So it's very flexible. And again, what we find when we implement trauma and grief component therapy are significant reductions in PTSD, depression, maladaptive grief, and also we see enhanced school connectedness. One more thing I forgot to mention is that we've also recently found that it reduces violent behavior in the classroom and in juvenile justice settings. So one more thing about that is that we've been holding learning collaboratives where we bring together many clinicians, usually 60 to 80 at one time. We train them in the intervention, and then we send them out to do the work while providing ongoing supervision and consultation for a full year. And what that does is that it helps the clinicians to feel comfortable and confident with the treatment itself. We help to troubleshoot obstacles that they may have been encountering, and it also helps with both fidelity and sustainability. And that's something that we can talk more about in just a minute. So what can educators do to support grieving students? So we touched on this before, but what we know is that it is so important to acknowledge the loss. What we hear from teachers all the time is, I'm not sure if I should bring it up. The student is returning, but I don't know if I should mention that I heard their cousin died. And the truth of the matter is those kids are thinking about it. And by validating them, by explaining that you're aware and that you're there for them, that can be incredibly helpful. We also want to empower students. So if a child is returning to school after having lost a parent, for example, we don't want them to necessarily be bombarded by students who approach them, but we want to give them choices. We want to give that student a choice of, one good example is I had a teacher who put all of the condolence cards from the kids in the classroom in one big envelope, handed it to that student who was returning from school after having lost his mom, and said to him, you can read these cards whenever you feel comfortable. So it wasn't like he had to be approached by all the students, but he had those cards with him whenever he wanted to look at them. We also want to give students words to express support. So just as we as adults struggle to find the right words after a loss, so do kids. And so we want to help to identify what are some things that you can say as another peer to support your friend. So things like, I'm so sorry for your loss, or I'm here for you if you want to talk. What we also want to do is talk a little bit about things not to say. So things like, I'm sure you'll be over it in a year. Kids give each other timelines for that. Or for example, your dad's in a better place right now. That is not very helpful. So again, helping to educate students about what they can say and do. We also want to, as I mentioned before, anticipate those very important loss and trauma reminders that might be happening in the classroom and prepare students for that. So for example, even just bringing home a permission slip that requires the signature of both parents can be triggering for kids. So anticipating what those are and then helping the students who are impacted to prepare for those things. We also want to recognize the adaptive side of grief. So we know that most kids who are bereaved are going to go on to live healthy, happy, productive lives. So we don't want to over pathologize grief. But on the other hand, we also want to identify those students who are at risk as quickly as possible so they can get the needed interventions that they so deserve. And so that's why we're also very invested in helping to train educators and school personnel to identify those kids who do need that higher level of care and make appropriate mental health referrals. So what can caregivers do to support grieving youth? We know that caregivers are key grief facilitators. And what we mean by that is that parents can engage in what's called positive parenting. And this is expressing affection, keeping routines, and providing structure. And we know that in the context of bereavement, these things are critically important. We also know that caregivers worry a lot about saying the exact right thing or having the perfect discussion after the death of a loved one. And what we've learned from our research is that when at a loss for the right words, the key is not what you say, but what you do. So one of my former graduate students, Danielle Shapiro, conducted a study where we looked at the ways in which surviving caregivers interacted with their bereaved children. And what we found is that it wasn't about what they said. It was really about what they did: the physical affection, the hugs, the smiling, the consistent eye contact, and being fully present for that child. So this can be very comforting to caregivers to know that oftentimes they're already doing what is most needed in the aftermath of a death, but to continue to engage in those behaviors that help the child to know, I am here for you and I am present. And so specifically, what can caregivers do when we're talking about separation distress? We want to help kids to find healthy ways of connecting. I want to give you a brief example. This was an illustration conducted by one of the patients that we had seen at the Trauma and Grief Center. And her father had died suddenly. And she drew this beautiful picture of her father in heaven playing cards. So he's here playing cards with his own deceased father. And then he's lying down in sort of his reclining chair watching TV. And the TV channel is permanently on what she called the family channel. And it's actually a channel that only shows her own family and what's going on in her family. And if at any point dad wants to be with them in a spiritual way, there is a little sign that says to real life, and he can come down in spirit form and be with them at any point. So I know this is a little bit of a tech savvy way of looking at heaven and you know the way she views the afterlife, but I thought it was just such a creative way of helping her to feel more connected to the person who died. And again, we want to harness those spiritual beliefs that for children feel comforting to them. They can write a letter. They can even write a response to the letter. So imagining they're writing a letter to the deceased person, what would they want them to say in response? They can identify mementos and they can talk openly about the person. And that is the most important piece, is having that open communication about the person who died. For existential distress, when kids are grappling with that, what we can do is help to identify traits or behaviors that they had in common with the deceased person, almost as a means of carrying on those traits and behaviors inside of them. They can find ways to carry on their legacy and find ways to honor their memory. And so what can they do that would make them feel like they're honoring the person that died? And then we obviously talked about this earlier, but to address circumstance-related distress, parents can help kids to brainstorm about what they can do to transform the circumstances of the death into something meaningful that can help other people. The first step in doing that, though, is being sure that the child feels clear about how the person died. So we know that before kids can make meaning of the death, they need to be able to make sense of the death. And that requires some sometimes difficult conversations about the actual way that the person died. And so the best thing that parents can do is be open and honest and use simple, developmentally informed language to talk about how the person died. And we know that that can actually be incredibly helpful to kids. So I'm going to end with this, my favorite Winnie the Pooh quote. And I just want to say that, the take home message here is that we know that grief is a reflection of how much we loved the person who died. And so for children, we want to reiterate that message, that that love that they had is something that can never be taken from them. And so with that, I will stop and turn to any questions that people might have.
Yes, thank you so much, Dr. Kaplow. We've gotten several questions from our audience, and in the 5 minutes that remain, we'll kind of toss a couple your way. So somebody in the audience said, are there indicators that signal if a child will be adaptive or maladaptive to grief?
That's a really great question. So oftentimes what we see that sort of raises a red flag for us among those kids that may go on to develop more maladaptive grief are things like extreme avoidance. So not wanting to talk about or even think about the person who died, risk-taking behaviors. So engaging in, substance use or driving recklessly, or sort of getting the sense that the child or adolescent doesn't really care about their own life. Functional impairment, if they're not able to get out of bed in the morning, if they're constantly crying, or if they're really not able to function in school. Those are just some of the things that we would be looking for that might indicate a more thorough evaluation is needed, and to be able to track that child over time.
Great. Yeah, and we have another one. This person says, what are some suggestions for getting into a dialogue as an educator, family member, etc., to see what type of distress a child might be experiencing?
That's such a great question. So, I think that sometimes, again, we don't have to have the perfect verbiage for how we approach a child, but even something as simple as, I've been noticing that you look a little bit down, would love to hear if there's anything going on for you. And not being afraid to ask those questions. I think sometimes we're worried about opening up a can of worms and, and then what do we do? But even just gently approaching that student in that manner can open that door to know, even if it's just planting a seed, that you're there as a caring adult if they do need to talk. And so again, making some statement to that effect that, if you ever decide that you want to talk, or if there's something on your mind, I'm here for you.
Great. Yeah, and this question came in during one of your slides with the examples. So this person says, are there similar patterns regarding the impact of trauma and grief on adults of anticipated deaths?
That is such a good question. And I didn't have time to get into this, but the answer is actually no. So what we find is that in the adults, they tend to have higher levels of PTSD when it is a sudden death, and lower levels when it's anticipated. So it's actually the exact opposite of how kids are handling that. And that's often what leads to those dyssynchronies in communication after a loss, where a parent may be saying something like, I'm just so relieved that they're out of their suffering, and that they do feel more of a sense of closure. And that child is left feeling like, wait a minute, that is so not how I'm interpreting this. And that can cause some problems in the immediate aftermath of the loss.
And this one is a little bit related to, it's about adults. So this person says, I've been struck by the prevalence of trauma. Half of US children will experience a trauma in their life, which makes me think about how many adults are walking around with their own trauma in the background and probably supporting children and others in their lives through their trauma. It's a lot. Given that, how can we also extend that support to ourselves?
That is such a good question. I think that's a really important point. And I think, one of the things that we're actively trying to do is help to educate educators and pediatricians and other providers, other caring adults, that they need to be fully aware of their own traumas and losses as they're working with this population, because we know that it can be actually triggering for us to be working with a child, for example, who, had a similar trauma as we did, or having students coming back to the classroom who had losses due to COVID when we've experienced our own losses. And so being self-aware of, how that's impacting you, building in your own self-care strategies, and that's something that we're actively working on with providers. And obviously, starting from the top down, helping organizations understand what is vicarious trauma, what does it mean to be providing a hope-centered organization, or an organization that's trauma-informed. So I think that's a critically important piece. And sadly, that's a talk in and of itself, but I think it's very important.
Gosh, I wish that we could just keep, people are asking wonderful questions, but we're short on time. So I see that you have a slide up here with more information. For those wanting to learn more about your research, about the TAG Center, can you speak to a little bit of these resources and how they can continue these
Sure.
conversations?
So yes, the TAG Center, that website has a number of resources that are freely downloadable for caregivers, other adults, focusing on how to help children who are grieving. So if you go to that website, you'll see that we have lots of different handouts, including focusing on how to talk to kids about a suicide death, a drug overdose death, other types of losses. That Lucene Center website is our clinical arm. So we have an affiliated group practice that is, again, affiliated with the TAG Center at the Hackett Center, where we see kids ages 7 to 21 who've experienced any form of trauma or loss. So if you'd like to make a referral, that's something that you can go to that website to look at. And then the last academia website has all of the papers that I mentioned today that are, again, freely downloadable for anyone. So if you go to that website, you can pick and choose whatever papers or empirical articles you think might be helpful.
Wonderful. I can't thank you enough. I'm just so grateful that you took this time today to share your expertise on trauma and grief. And I wish that we could keep talking, but thank you so much today. And also thank you to our audience for joining us. We hope that you find this series engaging and applicable to your work. And please mark your calendars for the next event on Wednesday, October 6th at noon Central Time. It'll be on financing evidence-based practices. So thanks everyone so much again, and take care.
Thank you so much.